Ready for part 2? Wonderful. We're jumping right on in. We're in the fast lane now. On today's episode of Make It Make Sense Cardiology Edition, we are going to talk about treatment strategies for atrial fibrillation. Now, if you have not reviewed part 1 of this series, I highly recommend that you do that because everything that I'm going to talk about piggybacks off of that. So, when it comes to treatment strategies for atrial fibrillation and or atrial flutter, we'll talk more discreetly about atrial flutter in a different post. But when it comes to treatment strategies, they are twofold. You've got either a medicinal approach with medications, or you've got a procedural approach, okay? Before you contemplate either medicines versus procedures, there's a couple things that you need to qualify first. First and foremost, when you have a patient who has documented atrial fibrillation, the conversation needs to be had about anticoagulation management. Just because somebody is in atrial fibrillation does not mandate that they have to be on a blood thinner. You have got to do the right thing for your patient at the right time and in the right context, okay? For example, if you have somebody who is in atrial fibrillation, new or old, if you have somebody who is in atrial fibrillation and they are admitted to the hospital for a GI bleed and their hemoglobin is only 4, don't put them on a blood thinner. Not good. If you have somebody who appears to be in atrial fibrillation and they are also being admitted for an acute stroke workup and no CT has been done of the head to rule out any sort of bleed, don't put them on a blood thinner. And even if that same CT has ruled out a bleed, there's no bleed on the CT whatsoever, you still need to wait until that patient has a consult with the neurologist to make sure that the MRI that's going to follow up, again, this is for stroke workup, to make sure that the MRI does not confirm the presence of a stroke either. Because if your MRI confirms the presence of a stroke and you introduce a blood thinner, you run the risk of what is called a hemorrhagic conversion. That means that area of stroke activity is going to bleed out even more because you put them on a blood thinner. And your purpose of putting them on the blood thinner may be justified as far as the heart, but now you're going to end up sacrificing the brain. Does that make sense? Yeah. So do the right thing at the right time. Well, how do you know if a patient is a candidate for a blood thinner? You know by way of a numerical scoring system called a CHADS-VASc score. Look it up. I'm not going to do the work for you. Look it up. CHADS-VASc. This is a numerical scoring system that each of those letters of that acronym stand for a certain ailment. And the more yeses you have to see if your patient has that ailment, then that is assigned a numerical value, okay? That numerical value will be tallied at the end of that scoring, and if your final result, your tally, is 2 points or higher, then you should have the conversation with your patient and their family to see if a blood thinner would be beneficial for them. All right? Again, I'm not going to go through the CHADS-VASc score. Look it up. Y'all are smart. You understand how to read acronyms and how to count numbers. You understand that. Moving on, medicinal control of atrial fibrillation. You have a lot of medications that you can choose from to try to treat atrial fibrillation. Oh, and before I get into that, you should also qualify your atrial fibrillation by duration of time, because that's going to govern which of those strategies that you use. So if your patient who is in active atrial fibrillation right here, right now, if that episode of atrial fibrillation has lasted less than 7 days, that is called paroxysmal atrial fibrillation. And there is a possibility that patients who have been in atrial fibrillation for less than 48 hours may spontaneously convert back to sinus rhythm themselves. It's possible. or they may need a additional assistance by way of medications. Take home point, paroxysmal AFib has a duration of less than 7 days. Persistent atrial fibrillation has a duration of 7 days or greater. 8 days, 9 days, 21 days, 30 days, 60 days, 90 days. It's more than 7, okay? That is your persistent atrial fibrillation. These patients may need a little bit more help as it relates to rhythm management. You may have to pull out your big guns, like your fleconides, your amiodarones. You got to pull out the heavy hitters sometimes with persistent atrial fibrillation. And then you have your permanent atrial fibrillation patients. Now, these are the patients who you have thrown everything in the kitchen sink to try to get them out of atrial fibrillation, from medications to cardioversions to ablations, and their heart is just like, this is me. This is how I live. You just gonna have to accept it. It is what it is. These are sometimes the patients that are considered for AV node ablation and a permanent pacemaker. But we will get into the specifics and the further details of that during another post. This is just for foundational understanding. All right. So now that you've got your anticoagulation conversation had with your patient and family members, and you've qualified the time element for duration of your patient being in AFib, now you can contemplate what strategy you are going to employ to try to either get the speed of this atrial fibrillation down, that's called rate control, or if you're going to employ medications to purposely convert them out of AFib and back into sinus rhythm. 2 of the most popular medications that are used for atrial fibrillation management are beta blockers. And I'm not going to reinvent the wheel with what beta blockers do and how they work. There's already a post on that. Pause this video if you need to and go back and look at the beta blocker video. Bring yourself up to speed. You're a smart nurse. Figure it out. And you have non-DHP calcium channel blockers. These are your diltiazems and your verapamils. Now, these non-DHP calcium channel blockers, and the DHP stands for dihydropyridine. Not going to go into a chemistry lesson. Now ain't the time. Just understand that those types of calcium channel blockers work directly on myocardial contractility. All right. So when you bring those calcium channel blockers into play, they literally tell the heart muscle, slow down, partner, slow down. Ain't even that serious. Chill out. Okay. And they work. They work 100%. They do. But they come with a caveat. All right. With non-DHP calcium channel blockers, you better bet your bottom dollar and make sure that your patient does not also have dilated cardiomyopathy. Dilated cardiomyopathy. We went over this in a previous post. Again, if you don't know what that is, put the pause on here and go back and check out that other video post. Dilated cardiomyopathy patients, your heart muscle is already weak, your heart muscle is already thin, the heart muscle, the left ventricle, is not squeezing like it's supposed to. So why in God's name would you employ a non-DHP calcium channel blocker that, again, it purposely tells the heart, whoa, chill out, don't beat as strong? Why would you bring that into a patient who already has dilated cardiomyopathy? That's less than smart. Unless you have no other recourse. Other medications, either, anyway, you just have no other recourse. You also have amiodarone. That's a very popular one that's used, especially in rapid atrial fibrillation. Now, again, if you have somebody who is in brand spanking new atrial fibrillation, never been documented before, and their heart rate is very, very fast, please make sure before you employ amiodarone that you have done one of 2 things. Either number 1, you have put them appropriately so on a blood thinner, because if you purposely cardiovert them and you have not made sure that they don't have any blood clots already existing in the lungs, then you have just rocket launched what a blood clot that could be in the lungs, or sorry, a blood clot that could be in the heart. You just rocket launched that out into circulation and increased the potential for stroke. So if you are going to employ amiodarone, you better make sure that this person is a viable candidate for anticoagulation, or you have gotten an ultrasound, an echocardiogram, to confirm the absence of blood clots in the heart. Okay? That's a lot of information. I've been talking for almost 11 minutes straight. I don't want to overwhelm you with information. Let's call this part a wrap, and I'll do a part 3 on the procedural treatments for atrial fibrillation. All right? Go get something to drink, go grab something to eat, and we'll pick this up later. All right? See ya.